Janiczek. My name is Michael, and I'll be today's host. To introduce him, Dr. Janiczek is a cardiothoracic anesthesiology fellow. He completed his residency in anesthesiology at the University of Illinois, Chicago, one of the top 30 medical schools in the country, in June, where he served as one of the chief residents for the final year. In addition to his clinical roles, Dr. Janiczek is the founder and CEO of Getting Admitted MD, the team advisor of the pre-med scene, and has served on a medical school admissions committee. A couple of reminders to our audience before we begin. We encourage you to turn your cameras on if you're able to. This session will be recorded and uploaded to our YouTube channel, and there will be a Q&A at the end of the session where you can unmute at that time, or you can feel free to write in your questions in the chat at any time, and we'll cover them during the Q&A. But with all those reminders and introductions covered, Dr. Janiczek, the floor is yours.
Awesome. Thank you so much for that introduction, and thanks for coming. Let me just share my screen here and we'll get started. All right. So like Michael said, my name is Dr. David Janiczek. I am a cardiothoracic anesthesia fellow at the Ochsner Clinic in New Orleans. And today I'm going to talk about the world of cardiothoracic anesthesia, something that's near and dear to my heart, and I hope I can excite some of you to go into it as well. So let's talk about what we're going to talk about today. So first of all, I'll give you a little bit of introduction, and then I'll talk a little bit about what is anesthesia in general. If you guys have seen my previous virtual shadowing sessions, I go more into depth into what general anesthesia is during those. Today, I'm only going to touch on the surface. Then we're going to dive into what is cardiothoracic anesthesia, what makes it different, what makes it exciting, all those sorts of things. What the path to become a cardiothoracic anesthesiologist is, and then maybe some reasons why you might consider becoming a cardiothoracic anesthesiologist. And we'll talk about a case that kind of highlights everything about cardiac anesthesia, and hopefully you'll be able to see why it is such an exciting field. All right, we hit on a lot of these. I'm originally from Iowa. I went to school at the University of Iowa, trained in Chicago, and now I'm down here in New Orleans, where I am doing my fellowship, and I will be finishing up next summer, finally. So let's just briefly cover what is anesthesia. So you guys have probably seen this before if you've seen my talk. Anesthesia is made up of 4 pillars: pain relief or analgesia, muscle relaxation or muscle paralysis, amnesia, which is the loss of memory, and then also unconsciousness. So the spectrum at the bottom here with the arrows, basically in the awake state on the left, a sleep state on the right, and then there's this middle ground, which we call sedation or monitored anesthesia care. So if you're awake, we can do some, minor surgeries with local or regional anesthesia. Local anesthesia, if you guys have ever had a dental procedure where they, take out a tooth or anything like that, and they injected some medicine in your gums, that's local anesthesia. Regional anesthesia is a step up from that. That's where we're talking about, numbing up an entire limb. So for, often for shoulder surgery or elbow surgery, hand surgery, we can actually just numb up the arm or the affected region, and you won't actually feel any pain from that, that surgery. And that's called regional anesthesia. We can do that various locations all over the body, the legs, the hips, and the arms as well. In the sedated state, this is where we give you a little bit of medicine, but we use medicines like midazolam or Versed, which is kind of like a liquid Xanax, an IV form of Xanax, if you will. We can use something called fentanyl, which has garnered a lot of negative press in the last couple of years for its abuse potential, but we use it every day in a very controlled manner for very effective pain relief. And so we can give you, kind of a combination of those 2 drugs and, get you in a nice sedated state. And then what most people probably think of when they think of anesthesia is general anesthesia. So this is where you're fully asleep to the point where we actually have to place a breathing tube in your mouth that goes down into your trachea. And that will help you breathe throughout the procedure. And for most surgeries, that's taken out at the end. You don't even know it's there. For bigger surgeries, we may have to leave it in and take you to the ICU with it in, and it's taken out at a later time. But that's, general anesthesia. And general anesthesia basically makes up or is made up of these 4 pillars. For sedation and local or regional anesthesia, it's not all of these put together. It's, just a couple. So moving on to cardiothoracic anesthesia. And so this is basically a subspecialty of anesthesia focused on taking care of patients undergoing cardiac surgery. It's definitely an evolving field due to the changing cardiac surgery landscape. So, years ago, 10, 15 years ago, they were doing a lot more cardiac surgery, just in general across the country. That has been changing. They're trying to do less invasive procedures if possible. So one way to do that is, instead of, having a patient undergo coronary artery bypass grafting or CABG, which I'll talk about later, we can actually just put a stent in their coronary arteries and, relieve the blockages that way. So that saved a lot of patients from having to undergo cardiac surgery. And these, transcatheter based techniques, which are called, are much, less invasive. There's less recovery time. Patients have to stay in the hospital for less time, sometimes even just, 1 day versus, sometimes for an open heart surgery, you need to stay in the hospital for a week. So it's just overall typically better for the patient. Now, does that change a little bit about, how we practice cardiothoracic anesthesia? Yeah, but we have adapted and, we're basically finding ways to stay involved and, take care of these sick patients nonetheless. Another big aspect of cardiothoracic anesthesia is what's called Transesophagealechocardiography, or TEE. So that is a huge part of our training as a fellow, is learning how to do the TEE, which I'll show you an example of later on. But basically, it's a ultrasound of the heart from the esophagus. So we're kind of, we place a probe inside the mouth, goes in the esophagus, and we can look out from the inside at the heart, and we get various images that way. We can measure pressures, we can measure flows through the heart, all types of cool information. So I'll show you a little bit about that later. So what's the path to becoming a cardiothoracic anesthesiologist? So you got to do 4 years of undergrad, which you guys are all doing, studying everything from art history to, biology to physiology, whatever you guys are studying, you can still become a cardiothoracic anesthesiologist. Then there is 4 years of medical school, just like everyone else. You rotate through all the same things that everyone else does. And then you just apply for anesthesia residency. This is 4 years as well. The first year being an internship where you rotate through different areas of the hospital. It's usually a lot of medicine. So medicine wards, the ICU, and you learn how to become, a doctor and write orders and all those types of things. And then you do 1 year of fellowship, and that's where I'm at right now. And so all of the, anesthesia fellowships are luckily only 1 year. And so it's not that much longer to add on to your training. And it, gives you those extra skills and, makes you more marketable for jobs in the future. So why would you want to become a cardiothoracic anesthesiologist? So I think there's multiple reasons. One of them, being you have to have an interest in cardiac anatomy and physiology. If you don't love, the heart and how it works and what it's made up of, it's not really for you. And so that was one reason why I chose cardiac anesthesia, is because I've always had an interest in, cardiac anatomy, how the heart works, how it keeps beating, continuously throughout, many, many years of someone's life. And so it's always just been super fascinating to me. I think another good reason is to, want to be involved in complex cases from the anesthesia side. Obviously, people who are healthy don't really typically get heart surgery. You have to be pretty sick to, need heart surgery and go through with it. So, a lot of times our patients have, multiple comorbidities. So, may have, hypertension or high blood pressure, high cholesterol, diabetes, they may have had strokes before, all these types of things. And so it's kind of a balancing act, and it's really fun to think about, okay, how am I going to take care of this patient in the safest way possible, and make sure that they get through the surgery in the best way. Another reason is that you get this echocardiography training. So this is a really beneficial skill, no matter what, if you're a cardiothoracic anesthesiologist and doing cardiac anesthesia in the future, or if you're just doing general anesthesia in the future and you have a sick patient that, may have some heart issues. You're trained and skilled enough to place a TE probe and be able to kind of investigate what's going on with the heart. So you're, kind of an asset to, whatever group you decide to join in the future, and you can provide that skill set and that expertise to them, which is always a plus. And which leads me to my next point. You may not always be doing cardiac cases once you finish training and you're out on your own. So you're able to take care of the really sick, complex patients that maybe some other anesthesiologists don't want to take the risk in, or they don't feel comfortable, taking care of. Patients whose hearts are not working properly, maybe they're a little bit depressed, with their ejection fraction or basically the squeeze of the heart, all those types of things. And so, you have the training and the, the level of comfort to take care of those patients, which is, a good feeling and is an awesome thing. All right, so let's move on to a quick case study. I will warn you, some of this stuff may or may not make sense at first. I'm going to try to explain it as best as I can. But I really want you guys to ask questions later on. If there wasn't something that made sense, or you guys just want more clarification, please just let me know and I'd be happy to. So our case today is a 65-year-old male presenting for coronary artery bypass grafting, or CABG, as it's affectionately referred to. So history of present illness, or HPI, basically he was mowing his yard last weekend, felt some chest tightness that radiated to his left shoulder. He went to the ER, was found to have ST segment elevations on his EKG. He was taken to the cath lab and was found to have 3-vessel coronary artery disease. And these are the individual vessels listed. So we can go over this in the imaging later, but the left anterior descending, the left circumflex, and the right coronary artery. So very major vessels in his heart, have pretty significant blockages. And so he's going to need some sort of intervention, to one, help his pain, but also to prevent him from having further damage to his cardiac muscle and muscle cells. So we learned that his PMH, or past medical history, includes hypertension, hyperlipidemia, type 2 diabetes, chronic kidney disease, heart failure with reduced ejection fraction, which was about 35%, which is a little low. Carotid stenosis, and he is obese. Social history-wise, he smoked for 50-pack year history. He drinks a glass of wine each night. He drinks a glass of wine with dinner occasionally, he says. So let's break all this down. I kind of talked about coronary artery bypass grafting, or CABG. So prior to stenting, so coronary stenting has been a very popular thing over the last probably 10 years or so, 10 to 15 years. And so what that is where they actually isolate the coronary artery that has a blockage, and they put a little metal mesh in there, and it kind of holds open the artery. Prior to that, CABG was the way to fix coronary artery blockages. So what that involves is basically taking a vessel, another vessel from the patient's body, and connecting it to one of the main coronary arteries, and then connecting it on the other side of the blockage to hopefully restore flow to the area that the coronary artery covers. And so, as you can imagine, this is not a small procedure. This is a pretty major surgery. And so, there's risk involved. Patients, have, obviously, poor outcomes sometimes from these procedures. So it's not something, to be taken lightly. By, dissecting the second part, the HPI, basically this is a classic presentation for someone with coronary artery disease. Some things that make it classic, chest tightness. Patients will describe it as kind of like a pressure, or an elephant sitting on their chest is usually how they describe it. And then one feature of this tightness and pain is that it usually radiates to the left shoulder. Some folks will describe it as to the left jaw, or to the back. as well. That's pretty common as well. These are kind of clues to, if you see a patient in the ER with this kind of description, then it's, kind of pointing you towards, maybe they have some blockages in their heart. Obviously, you have to do some more testing and figure out for sure, but it kind of heightens your awareness that might be going on. Another thing that, kind of tips your hand in that direction is he was exerting himself. So a classic presentation of blockages in the heart would be patients are exerting themselves, whether that's walking up a hill, walking to the mailbox, mowing their, yard. Most of the time, there's some sort of physical exertion when patients start to have chest pain. And so, asking, what were you doing when you had the chest pain is a very important question to ask when you first see patients with, presenting with these symptoms, and that can often lead you, down this path to the right answer. Going on to kind of the, kind of the workup in the emergency room. So ST segment elevations on his EKG, that's a classic finding for, coronary artery ischemia or lack of blood flow to certain areas of the heart. And then he went, the kind of the classic flow is then, you get taken to the cath lab where they take pictures of the coronary arteries using dye. And I'll show you an example of that coming up. And then you can kind of determine where the vessels are occluded and how severe the occlusions are. So moving on to the past medical history, these are all pretty classic findings as well for patients who come in with cardiac issues. Hypertension, high blood pressure is very common. And so, that's usually, part of the past medical history for these patients. High cholesterol, this can lead to, the physical blockages in the heart. If the patient has high circulating cholesterol, those cholesterol deposits can go into the coronary arteries and cause, those blockages to form over time. Diabetes, he does not have insulin dependent diabetes. He's got insulin independent diabetes. Chronic kidney disease, basically his kidneys aren't filtering the blood as well as they should. Heart failure with reduced ejection fraction. Basically, that just means that the squeeze of the heart is not as good as it should be. Like I said before, it's about 35%. Normal is around 60 to 65%. And so, it's never going to be 100%. The heart's not 100% efficient. And so, 60 to 65% is considered normal. 35% is reduced. And if it's below like 20%, it's, severely reduced and, the heart's really not squeezing at all. And then, most of the time the lack of squeeze could be due to, blockages in the coronary arteries, and therefore the muscle of the heart is not getting blood flow. Therefore, it's not really going to be working. And then lastly, smoking history can contribute to coronary artery disease and heart disease in general. And so it's also very common to have a significant pack year history. I think he said that he smoked 2 packs a day for like 25 years. So that gets you the 25 pack year smoking history. So let's move on to testing. So if a patient presented with this, kind of constellation of symptoms and description of what happened during the, onset of pain, we'd get basic labs. So those include, what's called a chemistry panel. So, sodium, potassium, all those types of things. We'd also get a complete blood count. So we look at his hemoglobin, look at his platelets, all those types of things to see where we're starting with. And then, we'd get an EKG, so an electrocardiogram. And so that would, kind of show us a lot of information, whether or not he has ST segment elevations or some other things that can show up on EKG, indicating, something's wrong with the heart. After that's done, usually coronary angiography, is interchangeable with transthoracic echocardiography. And so, transthoracic echocardiography can be done really easily at bedside. Most ER physicians are able to, put a probe on the patient's chest, an ultrasound probe, and kind of see what's going on in there. Coronary angiography, you need to go to the cath lab for, you need a cardiologist for. So sometimes, you just do a echo bedside and see, is the heart functioning properly? Is there, an obvious abnormality there? And then you move to angiography where you can actually see the vessels. And I'll show you guys all this here coming up. So here's an EKG. And so this is kind of your classic 12 lead EKG. So basically there's 12 different things that we're looking for. So each one of these lines at the top. So, you know, there's a little bit beyond the scope of this talk, but basically there's different leads we look at. So all of these correspond to, you know, different ways to look at the EKG. And so you get a few heartbeats in each lead. And then what you see here is right here, here, you see ST elevations. So in basically the segments of the EKG, you have the P wave over here, the QRS complex, and then the T wave ST segment here. And so you see ST elevation, which it should not look like this. This is very abnormal. And so, you know, if you saw this, you would pretty much know that there's, you know, probably some sort of blockage in his coronary arteries, causing ischemia or lack of blood flow to most of his heart. So this is an example of coronary angiography. You know, it's very complicated and, you know, hard to interpret. However, you can kind of just get a sense of, you know, these are his coronary arteries, these darker lines. And then if there's a blockage, you know, you wouldn't see you'd see kind of a, like a bottleneck, if you will. And so that kind of indicates that there's a blockage. And this is this isn't this patient's angiograph. So this is, you know, just a stock one, but you get the sense that, you know, okay, this is how the cardiologists look at, you know, the heart and be able to tell, okay, there's a blockage in, you know, the left anterior descending or the LAD. And so you would see kind of a lack of flow of dye through that artery. And then there's a grading system for how severe it is. So they usually do it in percent. So they talk about percent blockage of, you know, whichever vessels are occluded. And so that kind of gives you a sense of, you know, if it's, you know, only 20%, you know, there's still a good amount of blood getting through that, you know, but if it's 90%, you know, that's pretty tight. There's not a lot of blood flow going through that vessel. And so that would be, you know, one that could be the culprit of, you know, the chest pain and the heart attack that this patient is having. So then transthoracic echocardiography. So this is basically an ultrasound of the heart from the outside. And so you know, there's different orientations of the probe, everything like that. But basically you can get a sense of, you know, how the heart is squeezing, you know, are there any valvular abnormalities, you know, and which valves are abnormal. So basically this is like an inverted picture of the heart because we're looking from the front. And so this is the left ventricle, this is the right ventricle, making these the atria. And so you have the, you know, mitral valve, tricuspid valve. And so you can look at different orientations. So one big one for looking at coronary ischemia is this view or this view. And so basically what this looks at is the left ventricle. These are the papillary muscles within the left ventricle. And if this was a live image, you would be able to see it kind of squeeze. And so if there's a, we call it the donut view because it kind of looks like a donut when it squeezes. And so you can tell, you know, which wall of the left ventricle is, you know, abnormal, and that corresponds to a specific coronary artery. Typically, there is some ambiguity in some of the walls, but for the most part, you have a better sense of which vessels may be affected. You know, maybe before you get a angiogram. So. You know, we kind of get all this information. And then, you know, from the cardiothoracic anesthesia side, you know, we have to get ready for the case. It's not as simple of a setup as, you know, a lot of surgeries that we do, you know, in the general ORs or other types of surgeries. So, you know, we have to think about a lot of things. You know, one of them is, you know, how are we going to get this patient asleep? You know, we have many ways to get a patient asleep. And so, you know, in cardiac surgery, you know, there's some specific things we need to keep in mind and make sure that we, you know, don't do the things that will hurt the patient and, you know, maybe decrease their blood pressure too much. You know, some, you know, cardiac pathologies, you don't want their heart rate to go too high. Other ones, you want their heart rate faster and you want to avoid a slow heart rate. So all these things go into it. And so you have to know, which conditions do you need, fast heart rate versus slow heart rate, all those types of things. And so, the biggest question is, what are we worried about? So what's going to kill this patient? And so we want to avoid that and make sure that we don't do anything that will, even get us on the brink of that. So, medications are very important to getting this patient asleep. And so we got to be very, judicious with our medicines and make sure we have everything prepared. With that preparation, we need to think about IV access. So, for this patient having a CABG or coronary artery bypass grafting, we're going to need a central venous access of some sort. There's multiple options for that. So we can put in bigger ones, we can put in smaller ones. And so, this one doesn't necessarily, need a giant access line. We can get away with a medium-sized one, and that should be fine. If you're doing, for instance, maybe the patient has an aortic aneurysm or an aortic dissection, those patients need bigger, central venous access lines because they can lose a lot of blood and very quickly, just due to the nature of where they're working. For a coronary artery, bypass graft, we don't necessarily need, the biggest IV that we can, or the biggest central line that we can. We can get by with a medium one. And then there's also something in, cardiac anesthesia that's called a pulmonary artery catheter or a PA catheter. Basically, this is an extra piece of monitoring equipment we can insert once the patient's asleep that goes through, I say some of the central lines because the smaller ones it won't go through, but the large ones it will. And basically we can monitor central venous pressure, the CVP, or the pulmonary artery pressure. And so these numbers can help us kind of determine, does the patient have too much of, fluid? Do we need to, stop giving them fluids? Do they need more fluid? So it can change our management and, give us some more information that, we may not need, or we may not have without it. So I just want to go over kind of a general flow of a cardiac case. For most cardiac surgeries, we place what we call a pre-induction arterial line. So pre-induction means the patient's awake. And an arterial line is a special blood pressure monitor that usually goes in the wrist or the radial artery. So if you feel your wrist, on this surface, you can kind of feel your pulse. That's the radial artery. And so we usually place this monitor there because it's easily accessible. And so, the arterial line is placed so that we can have a blood pressure every single second of the case. So most people have probably seen the blood pressure cuffs that go on your upper arm. Those can really only measure every 1 minute at its finest. And in cardiac surgery, that's just too much time. So we need to have an instantaneous blood pressure. So if the blood pressure drops, we know it very quickly and we can intervene. And then once that's placed, we can go off to sleep. So that's induction of anesthesia. Just like a normal surgery, we give the medicines through the IV, get them off to sleep, like I kind of talked about already. And then we intubate them. So we place a breathing tube that's hooked up to our ventilator, and that gives them oxygen throughout the procedure. And then we also mix in anesthesia in the form of vapors that they breathe through the tube. And that's what keeps them asleep throughout their procedure. Once they're asleep, they have the breathing tube, then we can place the central line like I talked about previously. And usually we use what's called the right IJ, or the right internal jugular vein. You can use the subclavian vein. There's multiple places you can, insert it. And so it's kind of just institution specific. Once that's all done, then we can start doing our transesophagealechocardiography exam, which I'll show you a little bit about in the next slide. And so, that is really a lot of information that we can get very quickly by doing the exam. We can see how the heart's functioning, how the valves are functioning. It's a little bit better than the transthoracic echocardiography. Just because we typically get better pictures than the transthoracic. And so, we can do that at the beginning of the case, we can do it throughout the case, we can do it at the end of the case when the patient's coming off bypass and the heart's beating on its own again. And so it gives us a lot of information, kind of throughout the entire cardiac surgery. So just a brief overview of the surgery. So basically, they usually make a midline incision over the sternum, and so they dissect down, and then they do something called sternotomy. So what sternotomy is basically they use a saw to cut through the sternum, and so there's different techniques. Some are, a little bit longer incisions than others. Some are a little bit shorter, depends on the surgeon and their comfort level. But either way, they usually cut through the sternum. And that leads to a lot of pain, after surgery. And so one thing that we have to think about from the anesthesia side is how are we going to control that pain, post-operatively and make sure the patient's comfortable. After they get through the sternum, they continue dissecting. They open up the pericardium, or the sac surrounding the heart. And then if, for this patient, they're having a CABG, so, they're going to have to dissect the vessels that they're going to use to bypass the blockages. So a very common vessel that the cardiac surgeons use is the saphenous vein. So typically there's someone else dissecting the saphenous vein at the same time that the cardiac surgeon's entering the chest. And so the saphenous vein is removed from the leg. Luckily now we do it typically through a minimally invasive technique. So they've come up with basically a camera system that can go through one little port in the leg that they make. So it's a very small incision, and then they kind of dissect the saphenous vein up. And once they have adequate length of vein, then they take it out of the leg and sew up the leg, and then they move the vein up to the chest. And so before they can make any of these bypasses, they have to place the patient on cardiopulmonary bypass, which I'll cover shortly. But basically what that involves is cannulation of the aorta and the IVC. And so I'll show you a picture in a minute of kind of how the bypass circuit works. And I'll give you a lot more information about why we would do that. So once the patient's placed on bypass, we have to arrest the heart. And so basically we give a high potassium, the perfusionists give a high potassium solution that basically stops the heart. So if you're in the operating room, basically what you would see is the EKG is, beating along, and then all of a sudden it just goes flat. And in most circumstances in healthcare, if you have a flat line, it's not a good thing. But here we gave the medicine that did that. So we kind of know, we expect it, and so, at that point, the heart is no longer beating, and it will allow the surgeon to do his work. And the cardioplegia solution also helps protect the heart. So basically, by stopping its beating, it stops its metabolism. And so, the surgeon will also place ice on the heart. And so all these things together will help, hopefully decrease the amount of, ischemic damage to the heart while the surgeon's repairing it. So basically, once the heart's arrested, then he can, the surgeon, he or she can make the anastomoses with the saphenous vein, or, another common one is the internal mammary artery. So that's something that the surgeon will dissect, before making the bypasses as well. So after the bypasses are made in this case, then the heart is basically woken back up. So, we stop giving that cardioplegia solution, and the heart will start to beat on its own. Sometimes that, needs a little boost from some energy. So we may have to defibrillate the patient. There's special paddles. It doesn't go on the outside of the chest, it goes inside where the heart is. And the surgeon can place those paddles, apply electricity, and sometimes that's enough to get the heart beating again. Once the heart's beating again, then we can, hopefully come off bypass. The perfusionist, or the individual who's controlling kind of the blood flow of the bypass machine, they turn down the flow slowly and see how the heart's doing. At the same time, we as the anesthesia team will be giving them medicine. So, epinephrine or some other medicines that we have that, kind of help with blood pressure, help with the squeeze of the heart, everything like that. And that's called coming off bypass. The goal is that you come off bypass really smoothly. The patient's heart wakes up really well, and, everything is, going well. Sometimes that doesn't happen. We need to add more medicines, different types of medicines that affect different receptors, all those types of things. And so, that's where the fun of cardiac anesthesia comes in. And that's where, kind of the, cerebral nature of cardiac anesthesia comes in as well. You got to make decisions quickly. I'm going to go with this medicine and kind of see how it goes. And, watching their blood pressure, watching their heart rate, all those types of things continuously. And then, we can use transesophageal echo to kind of see, okay, the patient's heart is really squeezing well now. We can maybe come off our medicines a little bit, or, turn down the dose, something like that. And so, that's where the fun is in cardiac anesthesia. So once bypass is, kind of done, the heart's woken back up, everything like that, the sternum is basically reapproximated, and they put metal wires in to basically close the sternum together. And then they suture the skin together over top, just like any other surgery where they close whatever incision they made. And then, some centers will take the breathing tube out in the operating room and see how they do. Other centers will just go straight to the ICU with the breathing tube in, and the breathing tube will be taken out, maybe later that day, maybe the next morning. It just really depends on how the patient is doing. So a little bit on transesophageal echocardiography. I could do a 5-hour talk on this, it's pretty complex. That's why we do, a whole year of fellowship just to, really learn the intricacies of it. But here at the basic level, you see this, kind of diagram on the left here. And so transesophageal echo, basically we insert, it's kind of like a big tube, that we insert through the mouth, goes in the esophagus, and then basically takes pictures of the heart from the inside. And so you can see from this image on the right that everything is flipped, right? So from the transthoracic view, you remember that the left ventricle was up here and the right ventricle was up here. As you can see, this is flipped. So now we have the LV on the bottom, the RV on the bottom, and the atria up top. These are still the valves. So this is the tricuspid valve. This is the mitral valve. The aortic valve would be right in here. And so we have many ways that we can look, we turn the probe, we, can change the angle that it's looking. Basically, we want to get a 360-degree picture of the heart with this echo. And so, this gives us a ton of information. You can look up, like I said, pressures, you can look up velocity of the blood through the heart, through the aorta, all these types of things. So it's a really cool technology. And luckily it's getting better and better each year. And so hopefully, the next 10 or 15 years, we'll be able to do even more with the machines and be able to get even better images. So just a little bit on cardiopulmonary bypass. This is basically a diagram, kind of outlining what that means. So in the heart here, I kind of talked about this already. We usually cannulate. So we place a cannula usually it's in the right atrium and it goes down into the IVC or inferior vena cava. This will drain the blood into this reservoir. The reservoir also has kind of a heater in it to make sure it doesn't cool down too much. And then there's an oxygenator in this circuit. So the blood goes from the heart into the reservoir, into the oxygenator. And then it goes through the tubing into a roller pump, and the roller pump then basically pumps it back into the aorta. So the two parts that have to be placed by the surgeon include, basically a cannula or a big tube that goes in the aorta here, and then a big tube that goes in the right atrium into the IVC. And so you can think of this as kind of a drain, and then we return the blood through the aorta. And then once it's in the aorta, it can go to, the head vessels here. It can go down the descending aorta and into the rest of the body. And so the goal is that we perfuse the rest of the body, besides the heart and lungs. And so when you think of cardiopulmonary bypass, that's what we're bypassing is the heart and lungs. And so this machine over here basically does the job of the heart and lungs throughout the procedure. And so this whole machine is a whole standalone setup in the operating room. So if you guys have ever seen a bypass machine, it's a pretty big machine. And so there's a separate individual who's controlling that is called a perfusionist. So that's also a career in the healthcare field. that you guys can always do. It's, I think it's a 2-year program to become a perfusionist, where you learn how to run the machine, how you, can manipulate the machine to do what you want and do what the cardiac surgeon wants, because there's different types of scenarios that you'll run into with bypass and everything like that. And so if you guys, are thinking about, you want to be in the operating room, but you don't necessarily, want to be a surgeon or an anesthesiologist, perfusionists are always needed. We have a shortage of those right now. So that's also a good career. And so I basically, talked about all these goals already, but this is, a very simplified schematic, I will say, of the, kind of the bypass machine. All right, so coming off bypass, so we've done the surgery, the patient's, not waking up, the heart is woken up, but the patient's still very asleep. So basically it's an extremely tenuous time. So you never really know how the heart's going to wake up. There's some indicators. So, a younger heart is, typically going to do pretty well, versus an older heart, may have a harder time waking up. We may need to defibrillate the heart directly. That's what I kind of mentioned already. The surgeon can apply energy to the heart to kind of stimulate it. We use a lot of medications, so epinephrine, dobutamine are, a few that we, use routinely to kind of help the heart squeeze and help the blood pressure stay where it needs to be. We also are checking the function of the heart with the TE machine. We may have to place, a temporary pace or place temporary pacing wires to help the patient's heart just kind of squeeze rhythmically. Because sometimes, coming off bypass, the heart may only want to squeeze 30, 40 times a minute, which typically isn't enough to have the cardiac output needed to, maintain blood pressure and wake up from bypass. So, oftentimes surgeons will place pacing wires, and they'll pace at 80 or 90 or even 100 beats per minute, just so that we can get enough cardiac output to, kind of have the heart wake up. We also, may need to give blood or IV fluids. We don't always need to give blood after bypass. We kind of, we're checking labs in the operating room, making sure we keep an eye on, the patient's hemoglobin. And, if they, need blood, we can give it to them very easily. But most of the time we can get by with just IV fluids to make sure the blood pressure, is maintained. And if there's any sort of bleeding, from one of the anastomoses in the heart, we can always get blood for that. And, we kind of take it on a case-by-case basis. All right, so that's all I have for you guys. It's right about 7:45. Here's my contact info if you guys have any questions or want to know more about anesthesia. I'm always happy to talk about that. And with that, I will open it up for any questions you guys have.
Thank you, Dr. Janiczek, for the lecture there. Ahead of others having their questions, I have just a quick question. I know that you are on a medical school admissions committee. I'm sure that many of us here are wondering, what are maybe some examples of some applications that stood out to you when you were reviewing your, when you're going through applications in the committee?
Yeah. So obviously, those that stood out were the ones that, maybe had a specific, kind of story or healthcare experience that they really, showed and illustrated. Personal experiences with healthcare are very powerful. I read one, they had a very powerful experience as a high school student, undergoing, they had an orthopedic surgery, from what I remember, for a knee issue that they got injured during like high school sports. And basically the orthopedic surgeon took a lot of time with the patient and, answered all their questions, followed up with them. So it was really just a powerful experience that kind of motivated that applicant to, pursue healthcare and give back to others. And those are the ones that, kind of stick with you. A lot of people have good grades and good MCAT scores. but it's really kind of that personal connection, and the ones that are able to, show that on their application, typically stand out. So, if I could give any, kind of piece of advice, it's just trying to make it as personal as possible. If not everyone's going to have that kind of story, but if you can think of one, it's usually pretty powerful on admissions committees. And, outside of personal experience, if you have any family members who had, a battle with, cancer or something like that, and you kind of saw it through their eyes, those can be very, good stories to kind of weave into your personal statement and secondary essays and everything like that. And then outside of, those types of things, just kind of showing that you've done enough work and volunteering, shadowing, research, whatever it needs to be to you kind of understand what it's like to go into medicine. And so it's not a glamorous field in many ways, and so the students that know that and can kind of illustrate that that they're not going in it for the wrong reasons, those are the ones that often have very successful applications.
Thank you for that insight. Katie, you have a question? Go ahead.
Yeah, so first I just want to say thank you for speaking. It was so interesting and taught me a lot. I didn't even know this was like a thing or like a job. So it was super interesting. But I just wanted to ask, I recently was certified as an EMT. So when you were explaining his symptoms and like how it came about, the first thing that I thought of was like giving baby aspirin and like nitroglycerin. So I was kind of wondering, like, I know that I'm supposed to give those things, but I have no idea like how they would help at all. So I was wondering if you could explain how it would help in this situation.
Yeah. So that's great that you thought of that and kind of connected the dots. That's amazing. So baby aspirin would be more of it acts as kind of an antiplatelet agent. So it's going to thin the blood a bit. And therefore, if the patient has blockages in their heart, you don't want big, like thick, sludgy blood going through the heart. And so, the idea behind that is that it would hopefully thin the blood just a bit so that, it easily passes through those blockages that may be there. The nitroglycerin is it works on the blood vessels. And so it kind of relaxes the blood vessels, if you will. So especially the coronary arteries, it can kind of, open them up a little bit. So if you're having, stenosis or narrowing of a coronary artery, you can give them nitroglycerin. And, the idea is that it would open up, the blood vessels a bit. It's a temporary measure. And so, typically, a lot of patients who have heart issues, they are sent home with a prescription for sublingual nitroglycerin. So they would, put it underneath their tongue. And oftentimes, that's enough to get them from home to the emergency room where we can do more, more testing and make sure, that they're getting appropriate care. But that's, the basic mechanisms behind those things.
In terms of your journey, what specifically led you to cardiothoracic anesthesiology in specific, past just an anesthesiology residency?
Yeah. So my dad, when I was a sophomore in undergrad, he had a lot of heart issues. He got a ton of stents placed. And so it was really that process that, kind of sparked my interest in the heart and, cardiac anatomy, cardiac physiology, everything like that. I had a time period where I wanted to do cardiology itself, and actually be the kind of the person that puts stents in people. And the more research I did into it, the more I realized that it's a long road. So you have to go through, an internal medicine residency first, and then cardiology is a fellowship after internal medicine. And it's a 3-year fellowship. So you do 3 years of internal medicine, 3 years of cardiology fellowship, and then that's just to be a basic cardiologist. If you want to do what's called interventional cardiology, which is the people that place stents and do a couple other things, you need a fellowship on top of that. So you're looking at 8-ish years of training by the time, you'd be done. And so I looked at that and I didn't really necessarily want to go through that much training. If you put that into perspective, neurosurgery training is typically 7 years. So you're going to school or going to, residency for more, residency and fellowship for more than, a neurosurgeon. So I found cardiac anesthesia to be a really happy medium. I had always loved physiology. And so, combining physiology with, cardiac anatomy and physiology is, kind of the best of both worlds. And so In medical school, I did a research fellowship with a pediatric cardiac anesthesiologist, which, I don't want to do pediatric cardiac anesthesia, but I know some people do, and it's great. I'll stick with adults, but he really took me under his wing and showed me the basics of cardiac anesthesia and the, awesome things that are possible. So, it's a combination of all those things that, made me want to do, cardiac anesthesia.
I know that you've obviously chosen that specialty of cardiothoracic anesthesiology, but one person asks, what are some things that you did not necessarily like about your job? Is it maybe the paperwork, any administrative jobs or roles?
Mm-hmm. Yeah. So anesthesia in general, I'll start with that and then I'll go into cardiac anesthesia. So anesthesia in general is pretty unpredictable for the most part. Some other medical specialties have kind of gotten, or they figured out I work from 8 to 5 in a clinic. That's not really the case for anesthesiologists. We, relatively work for whenever there's surgery. And so it can be kind of tough at times for family life and work-life balance, being able to, if there's an add-on case and it's an emergency, it's 4 p.m. on a Friday and you're on call, well, you're staying to do that. And so, you don't get to leave at a specific time. You're kind of, you leave when the work is done for the most part. And so that's kind of an adjustment. And that's something that I don't necessarily enjoy about anesthesia, but it's kind of the way the system has been built. There is a push for more and more shift work. So, having defined hours, so 7 to 4 or 7 to 3, or, something along those lines. That's what emergency medicine has been doing more and more in the recent years. They're very shift style. And so anesthesia's tried to do it. Some jobs in the real world have that, most don't. Most, you kind of just finish when you're done with your cases. And so kind of that unpredictable nature, I wish was a little bit different, but it's not really possible to change. In terms of cardiac anesthesia, I would say dealing with the surgeons can be kind of tough sometimes. Cardiac surgeons are, notorious for not necessarily being the nicest group of folks in the hospital. There's a lot of egos in play. And so, if you do meet some nice cardiothoracic surgeons, it's a rarity. And so, I wish, maybe they were a little bit nicer, but at the same time, a lot of, they're dealing with a lot, and, I get it. So, most of the time it's okay, but sometimes it does get a little, there's a lot of tension, I will say sometimes.
Yeah. I think you already covered this a bit because you mentioned a little over pediatric anesthesiology, but do you have any rare cases where you do work with children or infants in cardiothoracic anesthesiology?
Yeah, so that's actually a different subspecialty, if you will. And so to do more like pediatric cardiac surgery, typically you have to do a pediatric anesthesia fellowship. And so, you go through the undergrad med school, the same, residencies the same, and then you basically do a pediatric fellowship instead of doing a cardiothoracic fellowship. And during the pediatric fellowship, you'll learn how to take care of the cardiac cases as well. I could do it if I wanted to do another 1-year fellowship after this in pediatrics. But those cases are very, very intense usually. And, it's a lot of stress, little kids, sometimes even just a couple days old, having some heart surgery, like that's a big deal. So, in theory, I could go to extra training and do it. But in my day-to-day practice, I will not be doing, children or infants.
Are there any tips or pieces of advice that you'd give to high school students listening in who would like to go into the medical field?
Yeah, I think the biggest thing is just try to get involved as early as possible. You never know what doors are going to open because, you did some sort of internship, you found a job doing something in the medical field. I would credit a lot of, kind of the things that I've been able to do, just to being, involved and getting involved early. And, trying to kind of get your foot in the door, because medicine is a small world. It seems like there's thousands and thousands of doctors, but people know each other. And so, there's often connections that can be made, even early on, and just kind of explore. And don't be afraid to say, medicine's not right for me. If you're in high school, then, you still have plenty of time. Even in, undergrad, you have plenty of time to kind of figure that stuff out. And so, kind of just make sure it's the right thing for you, shadow, if you can, shadow some physicians, do some virtual shadowing, talk to people, all those types of things, and just try to, figure out if it's the right thing for you.
To tag along with that, what piece of advice would you give to yourself about life or just in general pursuing a medical career?
Yeah, that's a good one as well. I would say, just try to take more time to, I guess, when I went through undergrad and med school and everything, there was always a push for, do your pre-med and undergrad education in 4 years, right? Don't take any more time, just do it in 4 years, go on to med school, do it in 4 years and move on. I wish, maybe I would have, not listened to that advice, I guess, or, not been so worried about the timeline. When you get out into residency and, even medical school, you realize there's a lot of older medical students, in their late 20s, early 30s. I even had a classmate in medical school who was 39. I think it was 39 when we started. People have second careers in medicine, like that's totally normal. Like it's not going to make you any less of a, good doctor. And so often those folks are, some of the better physicians actually, because they have life experience and they have, kind of a different perspective. Maybe they have kids already, those types of things. So I guess I would not have rushed to maybe do it so quickly and been so, I guess, focused in terms of having to get it done at a certain time. Because, you can always, you can make it work no matter what. And so, I wish I would have, maybe, did a 5-year undergrad and took things a bit slower, but then, really kind of enjoyed and learned a little bit more, I guess, outside of medicine and taken a couple extra classes, kind of more well-rounded, education type stuff. So, don't be afraid to take those classes, and you don't have to do science all the time.
Definitely. And more so shifting to your work-life balance, how often are you on call, and how is the lifestyle aspect of cardiothoracic anesthesiology look like?
Yeah. So myself, I'm on call basically once a week and then 1 weekend a month. That's my fellowship itself, the way that they set it up. And so every job in, kind of the real world is different. So I've actually been interviewing for jobs for next year already. And, there's a wide gamut of, maybe you're on call, 5 times a month, so about once a week, maybe a little bit more. The other end of the spectrum is, I've interviewed for jobs that were every other day you were on call, or maybe you're on call for a week at a time. And then, you have a week off, and then you're on call for a week and then a week off. And by week off, I mean, you're still working, you're just not on call. And so cardiothoracic anesthesia has notoriously been a very busy field. And it's not necessarily, to be honest, the best lifestyle field always. Now you can find little jobs here and there that are good, for work-life balance and good for, having a family and all those types of things. But there are definitely better fields for, kind of that work-life balance and not having to be on call a lot. Obviously cardiothoracic surgeons want to operate, they want to do as many cases as possible. And so if you're, providing services, anesthesia services to them, you're a little bit at the mercy of, them, and whenever they can do cases, you're going to be having to help. I guess the key is finding a group that maybe has, enough people in it that can cover, those cases, and you don't have to be on call every other day. And so it's just very, very dependent upon, the job, the group that you find in the future. If you're in academics versus private practice, all those types of things go into it. And so, roughly, it can be anywhere from every other day to once a week, I would say, on average.
And about shadowing hours, there's obviously programs like this one with virtual shadowing that are alternatives that are being offered during the pandemic. But for those who are interested in trying to get some in-person shadowing hours as the pandemic hopefully starts to die down, how can they make those connections and how can they network across to physicians?
Yeah, so I would say it really depends on if you have an academic medical center near you. That's usually a great bet. Those physicians are usually adept to teaching. They teach medical students, they teach residents. Usually they're more than willing to kind of help with shadowing or whatever they can do to help. And so if you have an academic medical center near you, I would reach out to that department. If you say you're interested in orthopedics, I would reach out to the orthopedics department, and just see if there's any options. Given the pandemic, it's a little harder, unfortunately for you guys. And I wish it was different. I wish it was kind of the free reign that we used to have in terms of bringing people into the hospital, but just with the restrictions on visitors in most hospitals these days, it's very tight, and it's hard to, sometimes get your foot in the door. But if there's no, academic medical center near you, so I would try to, reach out to, whatever specialty you're interested in shadowing, just Google that specialty in whatever city you're in and, kind of get a sense of which groups there are. Usually there's going to be multiple groups in that, area. It may just take kind of a cold email to the group, maybe a secretary, or if there's like a general info email online, or if that's not really an option, you can always call them and just call their general number and say, are you offering any shadowing at this point? I am, a pre-med, I'm looking to go into medical school, I'm really interested in this specialty. And so you may have to do this a few times before it proves fruitful, but hopefully you can find something that, someone that will allow you to do that and at least get a couple hours in, probably for the next, definitely this year, next year, and maybe even the year after that, application cycles, the shadowing component, we know that you're going to, have a hard time getting in-person shadowing. A lot of it's going to be virtual. And so, it's just something that medical schools are going to have to, accept and, there's really no way around it. But if you can get some, it'd be great. As the pandemic hopefully, lightens up a bit, but at the same time, if virtual shadowing is all you can do, don't, pull your hair out over not being able to get, in-person, shadowing.
All right. Well, thank you for that insight. That wraps up today's session. Thank you so much, Dr. Janiczek, for joining us today and taking time out of your schedule. For our audience to receive a certificate for this session, you must pass the quiz on our website, which is now uploaded. And be sure to join us for our next virtual shadowing session with Dr. Paulvan on October 6th at 7 p.m. Central. Thank you again, Dr. Janiczek, and have a good night, everyone.
Awesome. Thanks for having me.